Hello, everyone, and welcome to our Essential Tremor Virtual Education Forum. My name is Patrick McCartney. I am the Executive Director of the International Essential Tremor Foundation. Today, we're going to be hearing from Dr. Pravin Khemani on ET's non-motor symptoms. But before we get started, I want to thank our corporate partners, Cala Health, Boston Scientific, Praxis Precision Medicines, Steadyware, Incytec, Ball, and Allevion Therapeutics. Without their support, we would not be able to do these webinars and our podcast series. So thank you to them for their support of ET, the IETF. Now I'd like to introduce our speaker. Dr. Khemani is a member of the IETF Medical Advisory Board. He is also the Medical Director, Movement Disorders Clinic at Swedish Neuroscience Institute, Providence Health and Services in Seattle. He is his subspecialty. He is a subspecialty trained movement disorders neurologist with expertise in clinical treatment and research in Parkinson's disease, atypical Parkinson's syndromes, tremors, cerebellar ataxia, and dystonia. In addition to clinical work, he is involved in training medical students, residents, and fellows in the clinic and performing clinical research on movement disorders. So welcome, Dr. Khemani.
Thank you, Patrick. I'll go ahead and share my screen with you guys, and you tell me if you can see it okay. Thank you. Well, good morning, everyone. It's morning where I am, which is in Seattle, Washington. Thank you, Patrick, and thank you, IETF, for inviting me to talk about essential tremors, non-motor symptoms. Some basic facts about essential tremor. The prevalence is about 1.3% of the population, but essential tremors prevalence increases by at least 74% for every decade increase in age. And the incidence also increases with each decade. Interestingly, there is a bimodal peak, meaning people in the second decade and the sixth decades of their life are somehow more impacted by essential tremor. And then the highest prevalence is in people over 80 years of age. Men and women are equally affected, and there is a significant cost to society in treatment and rehabilitation of essential tremor. Hence, we need very good therapies and perhaps a cure for this condition in order to reduce the burden on the patient and the society. Essential tremor is artificially classified into two categories. I believe that this was for simplicity at one point, but truly there is a significant overlap. And in our clinic, we see essential tremor with a lot of other neurological signs, which seems to be the predominant presentation of essential tremor. In terms of the core criteria, the diagnosis of essential tremor is still dependent on identifying progressive tremors in arms. There may be tremors in the head, voice, people may have leg tremors, and these tremors need to be progressive over at least 3 years of duration to ensure that they have the appearance of essential tremor and not any other tremor. And the disease, the tremor is not a presentation of another neurodegenerative disease. And more often than not, essential tremor is present on both sides of the body, but it can be highly asymmetric. So we'll be focusing today on ET plus because we are going to be talking about non-motor symptoms of essential tremor or symptoms beyond tremor. There have been multiple studies done. Most of them are fairly small, but when you put all these studies together and you do a retrospective review of all these studies, it seems there are some commonalities and there are some common non-motor areas that are affected. They include the area of the brain, or rather the neuropsychiatric domain. cognitive domain, which is part of neuropsychiatric, but I've separated the two for ease of remembering. And then sleep and sensory areas are affected. And then there are comorbidities, which are other conditions that are prevalent to a higher degree in essential tremor than in normal controls, and we'll see what those are. In terms of the neuropsychiatric domain or neuropsychiatric symptoms of essential tremor, the two most common are mood disorders such as depression and anxiety. A fairly high percent of people with essential tremor suffer depression, up to 60%, and up to 22% may have severe depression. Depression can take many forms, but in essential tremor, it manifests as lack of interest, feelings of guilt, difficulty with concentration, and loss of energy. Interestingly, depression, and we'll see some other symptoms, is more common in people with a midline tremor, meaning tremor of the head, the voice, and the jaw. There is some correlation with tremor severity, meaning the more severe the tremor, the worse are neuropsychiatric symptoms. But truly, the literature is mixed on this, and we don't have definitive data to support it. It would be commonsensical to think that that would be true, but we need more information. In terms of anxiety, it is specifically social anxiety that is seen more commonly in people with essential tremor, and it is associated with females more than males, an older age of onset and prevalence, and interestingly, head tremor. So people with head tremor seem to display more social anxiety than people without. There are some personality traits that have been identified in essential tremor. Many conditions, neurological conditions, have certain personality traits. Parkinson's disease, multiple sclerosis. Now, it doesn't mean that everyone has all of the personality traits. This is just a collection of evidence or data over many, many studies. And it seems that the harm avoidant personality seems to be much more common in essential tremor. And the features of a harm avoidant personality include anticipatory worry, pessimism, fatigability, social apprehension, a self-reproaching a kind of behavior, overly cautious, and being overly skeptical. Now, some of these are present in all of us at any given time, but there is a higher prevalence of these in essential tremor to the point where these traits may interfere with interpersonal interaction and social interaction. So therefore, it's important to know that these are fundamental personality traits which may be addressed in counseling, etc. People with essential tremor seem to have more cognitive impairment than age-matched controls. And the areas of cognition that seem to be more affected are memory, particularly memory of events, concentration, decreased executive functioning and planning, sequential tasks seem to be more affected, and impaired abstract reasoning. Interestingly, the cognitive domain, like the neuropsychiatric domain, is affected more in people who have a midline tremor. So there seems to be an overarching maybe pathology that suggests that midline tremor is people with midline tremor have more neuropsychiatric and cognitive symptoms. And why is that? Well, one hypothesis is due to the connections between the cerebellum and the brain in people who have midline tremor seem to be altered in these particular areas. Sleep disturbance is common in many neurological conditions, but in essential tremor, interestingly, like in Parkinson's disease, there is a higher incidence of idiopathic or cause unknown REM behavior sleep disorder, which is enacting your dreams while you're asleep. Typically, when we are dreaming, the body is really quiet. All muscles are relaxed because some dreams can be vigorous and involve running, etc., and you don't really want to enact those dreams. But a REM behavior disorder is a sleep disorder in which exactly that happens. Then you can imagine it can be dangerous to your bed partner. You could fall out of bed if you're actively enacting your dreams. A REM behavior disorder is a very classical premotor symptom in Parkinson's disease, and it's quite prevalent in Parkinson's disease. People with essential tremor also have a higher prevalence, but not to the extent as in Parkinson's disease. So about 24% of people are affected by this. There may be a commonality in pathology. There are certain parts of the brain, such as the locus coeruleus, which degenerate in Parkinson's disease and which also show pathological changes in essential tremor. That could explain why REM behavior disorder is more common in essential tremor. And interestingly, people who have a rest tremor in association with the classical action tremor of essential tremor seem to display more REM behavior disorder. And that's interesting because it raises the question, are these people going to develop Parkinson's disease in the future? Because as we know, rest tremor is the classical tremor we see in Parkinson's disease. And action tremor is the classical tremor we see in essential tremor. Well, this fact is not settled, but it's just observed in clinics. Additionally, because of disturbed sleep, people with essential tremor suffer from excessive somnolence. Now, it is important to recognize that when we treat people with essential tremor and use medications such as trimetone or topiramate or gabapentin, all these medications cause excessive somnolence. And so it is possible that the excessive sleepiness during the day and some other non-motor symptoms could be associated with the medications that we're giving people with essential tremor. But case control studies have demonstrated that their non-motor symptoms, such as excessive somnolence, are present in people with essential tremor when controlled for the amount of medications they are taking. And unfortunately, if you don't sleep well, you have a lot of daytime fatigue. So, it could be a double whammy. People with essential tremor are predisposed to excessive somnolence and daytime fatigue, and then you give them medications that can exacerbate that, and that can really impair health-related quality of life. So one must be aware of that. In terms of sensory changes, the most common special sensory area that is affected is hearing. And there is a significantly higher percent of people with essential tremor with high frequency sensory neural hearing loss, which is related to the cochlea as opposed to retrocochlea behind the cochlea in people with essential tremor. And the mechanism, there are several hypotheses, but we really don't know. Is it the degeneration of certain neurons in that particular area? Interestingly, olfaction, which is sense of smell, is also affected in essential tremor, and it is affected in Parkinson's disease. It's a premotor symptom of Parkinson's disease, but we really don't have very good studies to demonstrate this. The literature is mixed. Some studies have shown that olfaction or sense of smell is affected. Other studies have shown that it is not affected. So more research is needed in this area, because when we have these common pathologies, it is potentially possible to develop common medications that can address both these conditions. All right, so what are the diseases that are more present in people with essential tremor than age-matched controls? We already touched on Parkinson's disease, and we'll talk about it in a little bit on the next slide as well. Up to 4 to 5% of people with essential tremor can go on to develop Parkinson's disease. The percentage may be much higher depending on the study and the methodology you're looking at. And in movement disorders clinic, due to the referral bias, meaning we get specifically people who have tremor, we probably see a higher prevalence of Parkinson's disease in people with essential tremor. Other conditions, including high blood pressure, pain disorders, hyperlipidemia, or cholesterol-related abnormalities, and type 2 diabetes are much more common in essential tremor. Interestingly, studies have shown that type 2 diabetes may also be more common in people with Parkinson's disease. So what is the nexus between essential tremor and Parkinson's disease? It seems like the risk of developing Parkinson's disease after having essential tremor for several years is up to 20%, but the risk is quite variable, which hints to the fact that maybe there is a genetic predisposition in some people. Typically, Parkinson's disease lags the onset of essential tremor by years. It's not the other way around. And on the neurological examination, the clues are that in addition to the classic action tremor, people with essential tremor may have rest tremors, that is, tremors at rest when they're not moving. Now, it is important to recognize that rest tremors may be present in advanced essential tremor without having Parkinson's disease. So that needs to be taken into account. But classical slowness of rapid repetitive movements called bradykinesia, which is present in Parkinson's disease and is one of the core criteria for diagnosis of Parkinson's disease, is present in people who have essential tremor in Parkinson's disease. Rigidity is stiffness of a limb, of movement of a limb about a joint. That is seen in people with essential tremor and Parkinson's disease because rigidity is a criteria for diagnosis of Parkinson's disease. And postural instability or impaired balance, I've put in parentheses, is actually quite common in both essential tremor and Parkinson's disease in the sense that people with essential tremor have impaired balance more than age-matched controls. And I'm not talking about that today because we are focusing primarily on non-motor symptoms. So impaired balance may not necessarily be a clue to separating ET and PD or identifying Parkinson's disease in people with essential tremor, but it is important to recognize. Now, people with essential tremor who have mild rest tremors but only mild bradykinesia, and we wonder, oh, do you have Parkinson's disease or not? Sometimes we can give them a trial of carbidopa-levodopa, the medication that is used to treat Parkinson's disease, to see if the rest tremor component improves. But when the signs are subtle, we may not always detect change appropriately. Plus, pill burden is high in people with essential tremor, and you're giving them yet another medication without knowing whether they have a coexistent neurodegenerative disease. So we do use tests such as a dopamine transporter scan, which has been present for a long time, in distinguishing essential tremor from Parkinson's disease. This particular scan, which shows the degeneration of dopamine pathways in Parkinson's disease, should ideally be normal in essential tremor. But it is also important to recognize that there are some false negatives and false positives. The false negative rate is higher than the false positive rate, and about 10 to 12 to 15% of people with Parkinson's disease or early Parkinson's disease may have a normal dopamine transporter scan. There are other tests that I have not listed on this slide, including the SIN1 biopsy, which is a technique in which skin biopsy is taken from 2 to 3 areas of the body, and it's analyzed for the presence of misfolded alpha-synuclein in the nerves of the skin and in the dermal nerves, which is seen commonly in people with Parkinson's disease. If we do this assay in someone with essential tremor who does not have Parkinson's disease, ideally there should be no alpha-synuclein. But if there is a high suspicion of Parkinson's disease, you do this test and the test is abnormal, then you can conclude that Parkinson's disease is coexistent with essential tremor. How do you treat someone who has both essential tremor and Parkinson's disease? You customize the treatment. Typically, the action tremor component of essential tremor is more disabling than the rest tremor component of Parkinson's disease. So we focus on treating the action tremor component, but when there is bradykinesia and rigidity, slowness and stiffness that are interfering with activities of daily living, we also do combination therapy with carbidopa-levodopa. All right, so one begs the question, why do people with essential tremor have these non-motor symptoms? Truly, the answer is not known, but there is some indirect evidence through functional MRI and diffusion tensor imaging. These are advanced imaging techniques which we don't use in clinical practice commonly, but they're used for research that demonstrate that the cerebellum, which is typically the hub of essential tremor generation, by way of its connections with the inferior olives, the brainstem, etc., the thalamus, has rich connections with other areas of the brain, including the frontal lobe, the temporal lobe, and parietal lobe. These are the areas of the brain that could be responsible for generation of some of these non-motor symptoms. The circuits that connect the cerebellum with these areas seem to be altered, seem to be firing incorrectly. And in FDG PET, fluorodeoxyglucose, brain PET scans that analyze the metabolism of the brain and show that there's decreased metabolism in some of these areas, meaning the metabolism is altered, maybe abnormal. It's an indirect clue that these areas are affected, but why that happens is an area of hot research currently. So in summary, I would say that essential tremor is a complex disorder. We know that it is defined by a progressive action tremor, which is very disabling. However, we must recognize that non-motor symptoms can also be present and impact quality of life. While more research is needed to understand the pathology or the cause of these non-motor symptoms, we must implement multidisciplinary treatment, which is essential, pun intended, to improve health-related quality of life in people with essential tremor. Thank you very much for your attention.
Right. Well, thank you, Dr. Khemani, for speaking with us today and sharing some great information on the non-motor symptoms of essential tremor, which I don't think a lot of people really think about. They're always thinking about the tremors in the hand. So we hope everyone found the presentation very helpful, and hopefully you learned something new today. I know I definitely did. If you have any questions regarding essential tremor, we encourage you to visit the IETF website at essentialtremor.org, or you can call us toll free at 888-387-3667. Finally, if you are a donor to the IETF, we thank you for your support. And if you aren't currently a donor, we hope you will consider a gift to help us continue to do the work we do, promoting ET awareness, education, support, and research. The IETF hosts a variety of these ET education events, so look for notices about these events in our Tremogram e-newsletter, on our social media, and in our Tremor Talk magazine. So Dr. Khemani, thank you again for joining us today, and we hope everyone has a great day.
Thank you, Patrick. Take care, folks. Bye-bye.